Right, good morning everybody. Welcome to the January meeting of the Care Quality Commission. Before I go into the businesses on the agenda, I just would like to start by offering the board's very public congratulations to you, David, on your knighthood. Hugely well deserved, not just for the work that you've done at the CQC, but for a lifetime of public service. And we were all absolutely thrilled. So congratulations. We have apologies from Eileen Milner, from Michael Marr and from Lewis Appleby. Otherwise, I think we're present and correct. Minutes of the meeting of the December meeting. Are they a true and accurate record of what we discussed? Thank you. There is nothing on the action log. Is there anything that anybody thinks is arising from those minutes that's not otherwise on the agenda? Perfect. Okay. So, David, we're straight over to you and the Chief Executive report.
Thank you, Peter. So this is essentially an updating report. The first section is really an update in relation to the performance of the wider organisation. We've covered in some detail the progress on the inspection programme. All are on track to be completed by the end of this financial year. Andrea, Mike and Steve with their teams continue to work on the timeliness of reports, and the detail of that is set out, and the registration improvement programme continues to make progress. Picking up on a theme which was in the State of Care report, we've provided some updated numbers in relation to services which have improved their overall rating on re-inspection, and they're pretty similar to the ones that we set out in some detail in the State of Care report last October. Enforcement activity is running at a high level, where we've taken the 12 months to date just over 1,600 enforcement actions, with a further just over 1,000 in progress. There's no specific updates from any of the three inspection directorates, but attached to Annex 1 is the detail of the performance report for the last month. The rest of the report is an update. Paragraph 5, I just update on winter pressures. The Secretary of State for Health gave a statement in the House of Commons on the 9th of January, reflecting on the pressure that the NHS had been under during that first week in January in particular. And we'd been asked, as a consequence of that announcement, to look at whether we could undertake some rapid re-inspections of services where, as a result of our inspections, we had some concerns about the safety and quality of those services, and therefore there were some restrictions on either admissions or in the way that those services were being used locally. We think there are three reasons why there are restrictions. It could be because of what CQC has done, it could be what local commissioners have done, local authorities, the CCGs, or indeed the providers themselves deciding that they're going to exit the market. So we need to be careful not to conflate what are three very different things. So the action we can take, and Andrea and her team have been looking at this. We're still looking at the data that sits behind this. Malta's team have dug out some data which, from April 2015, total number of beds that have been reduced is 4,000. That's about 0.7% of the total number of beds. There are regional variations in this, so some regions have more, some have less. But of direct enforcement, it's about 550 beds which have been affected by what we do, which on the arithmetic that the team have carried out is about 0.1%. So the intelligence that we hold at the present time is this isn't a big number, but it is a number, and therefore we'll continue to do that work and do the analysis and look at this. We need to look at where as a consequence of inspections, providers decide they're not prepared to continue, i.e. they voluntarily exit the market as well in relation to this. I suspect as we dig into this and better understand this data, there'll be as many implications for the way that commissioners commission services and the quality and price that they're commissioned to as there is about the action that we take. But because there was a public statement by the Secretary of State at the beginning of January, we wanted to cover that in this report to the board and just give you an update on that. And Andrea and her teams are working hard on this. And we've got some discussions with NHS Improvement as well. Next item I cover is a staff survey. We're going to touch on this in some detail later this morning, but we'll bring a report to the public board meeting on to the February meeting tomorrow. In actual fact, the senior leadership team, which is the executive team plus all their direct reports, are going to spend a part of some time that we've got together tomorrow going through the actions that are being discussed in work groups. So what we can bring to the board in February is not just the detail of the staff survey, but the actions which are being pursued as a consequence of the staff survey. I'm updating the board in relation to experts by experience. Our view is that positive progress is being made by the providers, by Remploy in particular, in relation to managing the contract. As is what appears to be now a tradition, I think board members would have received an email at the beginning of this week from a group that contained their view that there were still problems with this contract, and my view is that there are and continues to be issues with the contract, but the contract is performing at the contract level. And so I'm not going to go through each and every item in this meeting that was raised in those letters. It's very difficult to deal with what is effectively an anonymous letter creating anonymous cases. Chris Day, who leads on this for us, and senior people in Remploy are more than happy to meet with the people who are writing in on a monthly basis to the board as a way of taking this forward. So I think that's the spirit we'll go back to people. If there's still outstanding issues, then we're quite happy to set up an opportunity for those to be discussed with the people that are raising the concerns. We'll continue to monitor the contract, and as I say, I think the figures are demonstrating that the contract conditions are being met by our employee in terms of fill rates. The November data, which was the last performance report, show that performance is being maintained. In paragraph 8, it was a busy week, the week that Parliament came back. The Prime Minister gave a speech in relation to, amongst other things, mental health services, and made a commitment which confirmed what we'd been asked to undertake, which is a thematic review of child and adolescent mental health services. So that work and the detail of that work is being scoped and the timetable is being developed over the next few weeks, and that will be brought to a future board meeting before we start. We just want to make sure that some of the detail. I think there have been that many reports on child and adolescent mental health which say it's not very good. We need to be really clear what it is that we're going to add to those debates rather than just amplify and repeat what many people have said over, to my calculation, 20 years, quite frankly. So we're working hard at doing that, and we'll bring that back to the board. And then finally, colleagues, I'm just flagging up the consultation documents that are currently out. They close on the 14th of February, I think, and hugely important that we get the feedback on the changes to the assessment framework and the particular changes to the way that we're going to do the NHS work. But that's a report, Peter. As I say, the majority of that's for noting, but colleagues might have questions or comments that they want to raise in the conversation. Thanks.
No, thank you, David. Jane.
Thank you. Just two comments, one on the winter pressures and one on CAMS. And I went off to ask my colleagues, winter pressures, what are we hearing about it? And it's not actually sort of rolling in through our doors. Whether people are just so busy suffering from winter pressures, they're not thinking, oh, I must tell my health watch about this. But what we are hearing about is particularly about A&E, and that's more on the area of people almost holding back from they recognise the pressures and they don't want to sort of go into A&E unless they have to. And we've got one gentleman who thought, oh, I won't go to the A&E, I'll go to a walk-in centre. And the walk-in centre then said, no, you need to go to A&E. And he had something in his eye, so they said, well, you can't drive, you must leave your car here. So they took him over to A&E. The nurse in A&E said, no, you don't need to come here at all. She just, whatever it was in his eye, got it sorted. So there he was, left at A&E without a car and no one to get him home. So it's that sort of thing we're hearing about. So I think there's something about signposting for both inside the service but also outside the service. But people are generally trying to use the facilities as best they can. The other point was about CAMS. I echo what David says entirely. We do have a wealth of evidence on this because, as you say, it's been well-trodden territory. Very happy to contribute in any way that we do use that rich seam of evidence.
Good, thank you, Jane. Paul?
Yes, on winter pressures, have we got any idea what the spare capacity in the adult social care sector is, leaving aside our role in that? Just whether there are hundreds of beds not being used.
Well, do you want to do the figures?
Andreas?
Go on, Andrea.
God, everybody volunteering. Right, Andrea, you start.
That's not kind of figures that we would have for the whole of the country. We do have some understanding of occupancy levels in the services that sit within the market oversight scheme, and they are at a very high percentage occupancy in terms of that. But that's not data that we routinely collect in that way. We will, through the registration data, have an understanding of what the numbers of available beds would be. And what we also know is that there is a high level of turnover within those beds. I think that the key thing is that at a local level, that we need to be making sure that the local authority, the clinical commissioning group, our team, as well as the local hospital, are working closely together to understand, on their local patches where that capacity is. If that capacity has been restricted for any reason, and frankly, we only restrict the capacity if we have very serious concerns, and the service needs to have that ability to improve. Again, if we're taking action which takes capacity out of the system, we're doing that because there are serious concerns and fears for people's well-being and safety. So I think that the critical thing is for this to be handled within those local patches and that good sharing of information. And we do see some very good practice happening across the country around that, where we are able to highlight to the local NHS and the local authority where we've got potential concerns, and the local NHS actually assisting in terms of supporting the care home to improve, to actually kind of strengthen the skills of their staff so that they can continue to operate in a way that's actually safe and appropriate for people who are using those services. But unless Malta's got better insight than I have, I don't think we could give an overarching kind of number of beds that are currently available.
That's right, Andrea. What we do know is the total number of beds in England, and that number has been fairly constant over the last 6 years or so. One of the indications, I think, of that is that partly more people are being treated at home rather than in a care home, which is the right development. But it also raises the question to what extent capacity is keeping up with demand, because we know that over the same time more people are in need of care. That's not an answer that's a question we can answer at this point, but we know that the number of beds, so there is a question whether the number of beds capacity is keeping up with demand.
Because what the Secretary of State was interested in is the ability for social care beds to be used to assist the NHS. And in a sense, what there is two markets here. And there could well be a lot of social care beds not being filled because the money isn't going in to fill those beds. Because this was the case certainly a year ago. And so the reason I'm bringing it up is that I think our intervention is probably a very small part of the beds that are not being used. And we've got a very specific set of interventions that you outlined why we do it. We don't close beds because we like closing beds. We close beds because these are not beds that we are saying patients should be using. So I think that I just think there's something odd where we're being asked to look at 550 beds, and I suspect there are a couple of thousand that are not being used because the adult social care market doesn't provide the money to use those beds, but the NHS could step in and use those beds. And so I think that precisely the way in which you were talking about it, which is local NHS, local care providers, as well as local care commissioners getting together and saying how over the winter can we utilise this capacity, which won't necessarily be needed in the summer by the NHS, but is there, I think is what's needed, and we are a small part of that.
And certainly we know that there are examples across the country where that has indeed been done, so that the local NHS providers have directly commissioned services within adult social care beds, which I think particularly is helpful if it's clear that this is a step-down facility, so that what we're doing is not actually institutionalising people inappropriately, because place that most people want to be is in their own home. But I forget what the statistic is, but there's a very significant proportion of people who do get discharged from hospital into a care home who never go home, because the expectation is that they will continue on. And that may not be the right thing for them, but to actually have a period of rehabilitation support, confidence building, all of those kind of things with the skills that people in adult social care services have to do that, that could be a much better outcome for individuals and also help the system more broadly.
Okay. We will nevertheless do what we've been asked to do by the Secretary of State as well. Robert.
Different area. The appendix, which I printed out so I could actually read it. Not that I necessarily understand, but just a question about the little table on the page 2 of it, the fit and proper persons, the duty of candour. And I think I understand the columns, and forgive me if we've all had this explained to us before. But I don't quite understand the relationship between the percentage of enforcement and the number of management reviews, and they don't sort of add up. So is that because we enforce the duty of candour and the fit and proper person test otherwise than through a management review? Do you see what I mean? Because there are, I mean, it's obviously the figures vary from sector to sector.
I can certainly give a view from hospitals, where we have a panel meeting, which would be one meeting where we may be discussing several different individuals in terms of directors, in terms of fit and proper person. I don't know if that helps or doesn't, but that's what happens.
No, I'm trying to understand how the table works, that's all. It's, if you take the simple example of duty of candour for unspecified, there are 2 MRs, 50% enforcement, and 2 enforcement.
Which could be that more than one person is discussed at the MR, at the management review meeting.
I see. So this table doesn't tell us how many individuals a concern has been raised about.
Yeah. That I think might be the flaw in the table.
And frankly, I would have thought that's quite a useful piece of information for people to have, if it's possible to do without prejudicing any confidentiality requirements.
And certainly for hospitals, we have previously given that figure, and I think we can give that figure.
Thank you.
Okay.
I mean, I think there is work that's being done on, from an enforcement point of view, around how A, we collect this information, and B, how we can present it to the board in a more meaningful way. And that's one of the reasons why the data is a bit out of date in the table that you've got at the moment.
Could I just ask for clarification? Because talked, when there is a column, when there is enforcement which would register in this column, what are the sort of things that that includes? Is that a notice? Is that an informal request that a trust might investigate something better or correct a duty of candour issue, or is it more formal than that?
In terms of the enforcement,
yes,
yeah, it would be more, if we've said it's actual enforcement, it would be more more formal than that. It would be a warning notice.
Warning. Thank you.
I think there's a sort of general point as well, Robert, that if you know, we have so much data and trying to present it in a way which is manageable for us as a board, but if we're missing something or we've got something that it doesn't meet your or any other board members' needs, I mean, let's have that, not now, but let's have that discussion.
Well, obviously, we have this discussion every time, can I have this piece of information, and then someone changes their mind about it. It's simply that, obviously, in performance terms, the number of management reviews we have is important, but actually the outcome of that, I mean, what is important is what the demand for the service is, in a sense. So how many people are there sufficient concerns raised or incidents in relation to duty of candour that actually require us to pay attention?
Yeah, I absolutely get the specific. I was just trying to broaden it, so if there are other issues that you or any other board member thinks we're not capturing in the most useful way, at the risk of reinventing the wheel every time, let's look at it. Anything else anybody wants to raise on David's report? Okay, so is there any other business from board members? Perfect. So we are doing well time-wise. So we can now move on. Are there any points? Simon, you were first. Go.
Oh, sorry.
And although we know you, just for the record, if you'd be kind enough to say who you are, that would be nice.
Good morning. I am Cyan Irwin. I'm a patient safety campaigner. Happy New Year, board. Fingers crossed for 27 things. 17 of things improve somewhat. I have a thank you, a question and a clarification, if that's all right. I'd like to say thank you to Andrea and her team for the elderly man. We had to make a report, or I had to make a report with Islington Police over finding an old man out in the street, and Andrea's team have been great. We have 3 old men who are being seriously abused, but we'll get there in the end. This is a question for Mike, if you don't mind. Mike, could you define well-led for me, please?
Shall I take that? I can certainly tell you the approach that we take to assessing well-led.
Okay.
There are a number of different components within that. The first is that we assess the capability and capacity of the range of leaders in an organisation, and in a hospital that would include the board, the chief executive, medical director, director of nursing, etc. We then look to see whether they have a vision and a strategy, and whether that vision and strategy is actually being implemented. We look at their governance arrangements. In other words, would they know where their problems are, and to what extent that actually matches what we find on inspection, or do we find a whole lot of things that they don't know about? Very importantly, we look at the culture of an organisation, the degree of engagement of staff, because we think that is so critical to how an organisation performs. Clearly, the staff survey is an important element of that, but it's also the focus groups that we hear and the conversations we have with staff around a hospital. We look at degree of patient engagement. We look at degree of external engagement with other people in the health economy, health and care economy indeed. We also look at what innovations there are within the trust and what they are doing to make improvements, and what is their approach to doing that. So all of those things are individual components of our well-led framework, which is it's actually laid out in the consultation that we're going through at the moment, but those are the main headlines.
Okay, so just a question for that. Are there, or how many breaches of the Mental Health Act are acceptable per patient, say by a clinical director or doctors at higher levels?
we would make a rounded judgment on that. We would not have a certain specific number on there, but we would take those things into account as alongside all the other components that there are within well-led.
So there's no criteria for breaches of Mental Health Act or Care Act per patient, where if there's been multiple breaches of the Mental Health Act, you don't...
Well, if there are multiple breaches, we would certainly want to know about that, to discover that, and that would influence our judgment, yes.
OK, so when you're writing the review for West London, I know I was interviewed in, I think it was November, I think when they did it. Anybody? Was it November when West London were reviewed? I think so, yeah. I was interviewed and I gave some information about Robert Bates's breaches of the Mental Health Act as clinical director. So it seems to be that that's not really been taken into account in the way that I understood. So I just wanted to understand what the well-led thing is. So I know if it's happening with one or two patients, it's definitely happening with more, and it certainly seems to be reported with them at their group meetings. So maybe just if you have a look at that. Just one more thing, and then I'm going because I give everybody else a chance. Is there any clarification around the 20th? Thank you for the ticket, by the way, for the 20th. But is there clarification around the 20th that it seems there's a group of whistleblowers only being allowed to go in the afternoon, but the meeting is in the morning? So I'm not really quite clear how that's working. Anybody have any ideas? Exactly, the National Guardian, Robert, exactly.
Thank you.
Sorry. I wasn't too clear about
what the 20th was. I was just getting there. David, do you have any information?
So that's not something that this board is overseeing?
Oh, right, okay.
The National Guardian...
I thought she was reporting to you, though.
No, she has an operational independence.
Okay.
I need to account for the money. We host the function. But Henrietta has the role, and she discharges that function on behalf of CQC, NHSI and NHS England.
But doesn't she report back to you? No?
She doesn't report to me, no. She's not accountable to me.
All right. Who's she accountable to, then?
It's a role which is established. I occupy the role of accounting officer, so that if the Public Accounts Committee wants to know what the money has been spent on, they would expect me to explain what she's doing and what the money is. But in the same way that I'm the accounting officer for this organisation, but I am managerially accountable for Mike, Andrea, Steve,
So
Malta, etc. I do not enjoy, or she does not enjoy, that relationship as Andrea and Mike. Steve will tell you, enjoy that
how
relationship.
Lucky you are, Andrea. You never knew, darling. You didn't know. So
it's completely independent of you ask Henrietta.
Yeah.
It's an independent office of the National Guardian.
Because I think there's a meeting on the Friday morning, but what they've done is they've actually taken the whistleblowers and put them in the afternoon, separate. They've kind of segregated them from everybody else.
And they are operationally independent, and I'm sure you, Cyan, along with others, will be the first to say something if
well, I'm glad you have such
function.
faith in me, David. Thank you.
Thank you, Cyan.
Thank you very much, Board.
Does any other member of the public want to raise anything? Yes, come on. Yep. Robin.
Thank you, Chairman. Robin Pike from Hertfordshire Health Watch. Two brief questions, if I may. One in relation to the next phase of the regulatory approach, and one in relation to communications. As I come from an education background, I am aware of how much dialogue there is in a school inspection between inspectors and pupils, and between inspectors and parents. In the next phase of the regulatory approach, will there be more opportunities for conversation with patients and relatives?
Shall I take that one to start with? I think the key thing to say is there is a lot of conversation with patients and relatives already, and we want to extend that and find the best ways of engaging with them. So we started with listening events, and they were variably attended, to be honest, and we tended to get very polarised views with both people who are hugely supportive of a trust and those who are not so would attend. but really the numbers were quite small in comparison with the numbers of going through a trust. So we are now been looking at different ways, and for instance just having a stall at the front of the hospital and letting people who are coming through, and there are thousands going through a hospital in any one day, and we found that, for example, to be a much more successful way. And when we're on the wards, we talk to patients, we listen to patients, and so we are doing a lot of that already, but we are always willing to look for new ways of actually hearing those voices, because they are absolutely critical to us. And then, of course, on top of that, we do have the patient surveys that we do, which are standardised, like the inpatient survey or the A&E survey or the maternity survey, which give us useful information as well.
And I think I might just add, I mean, that's sort of during the inspection, but the strategy very much, as you know, going forward is about being intelligence-led, and that's actually collecting views of service users, their families, patients, Health Watch, to inform what's going on and to inform our own decisions. So I think there's a lot of dialogue there as well as during the inspection itself. Okay, you had a second point, Robin.
Yes, thank you, Chairman. Some time ago, I did ask a question at the board in relation to the planning of a television documentary along the lines of a day in the life of a CQC inspector, as this might balance some of the media coverage in the Daily Mail or the Times. And I wondered whether there is progress on such a TV documentary.
I think that goes into the category. It would have been helpful to have had advance notice of that question. Can we come back to you on that? I'm certainly not aware of anything.
Well,
David, if you can add it.
I know Chris Day, our Director of Engagement, continues to reflect on this, and I think it is something that we're open to, but we've not made anything happen. But we're alive to the opportunity that might be presented by that. But there's no firm plans at the present time. There's a straight answer to that.
Thank you. Thank you, Robin, very much. Does anybody else want to raise anything? Great. Well, this is a good start to the new, actually finishing ahead of time. So thank you all very much indeed for coming today, and no doubt see many of you again in the February meeting. Thank you.